Thank you. So we'd like to acknowledge our DoD support. And this is our standard DoD disclaimer. For those who are not familiar with the Role 2 atmosphere, this picture is representative of an established Role 2 facility. Here, general surgeons perform life-saving resuscitative surgery, including orthopedic and limited neurosurgical procedures in a forward environment. Note here the lack of a CT scanner, the absence of neurosurgery, and the fact that there are 2 OR cases ongoing in the same room. It's important to clarify that these are not necessarily trauma surgeons, but a wide collection of surgeons and non-specialists. General surgeons who are deployed to forward units are constrained by limited resources and challenging clinical scenarios, especially when confronted by severe traumatic brain injuries. Today, we suggest that the surgical readiness for these injuries can be improved. FSTs may vary widely in their physical makeup and the supplies that are available. They can be hard or soft structures, and these pictures are representative of some of the conditions that may be present. So a little bit of background. Previous research presented at SAGE's 2017, the Military Symposium Forum, demonstrated that there was a significant percentage of deployed surgeons who had limited experience and comfort when tasked with performing emergent neurosurgical interventions. We hypothesize that this may translate into less experience with medical management of severe traumatic brain injury. Although combat wounded require care in austere environments, surgeons do have interventions available, both medical and surgical, and the primary medical interventions exist in the form of hyperosmolar therapy. The use of this therapy is outlined in the JTS, or the Joint Trauma Systems Clinical Practice Guidelines for neurosurgery and severe head injury. The JTS has emerged as the de facto standard of care for the battlefield based on continuous reanalysis of in-theater data. So we ask the following question: are Role 2 surgeons adhering to the clinical practice guidelines that are available? And in particular, are they utilizing hyperosmolar therapy? The goal of this question was to serve as a surrogate for medical management of severe traumatic brain injury and documentation. So we performed a secondary analysis of the JTS Role 2 database from Afghanistan over the time frame of March 2011 through August 2014. We utilize this time frame in particular because this is what we have data for. Our population of interest was patients who arrived to a Role 2 facility with an initial GCS between 3 and 8 and an accompanied head injury. We examined both the medical and surgical interventions that were primarily neuroprotective in nature. This included neurosurgical interventions such as burr holes, craniectomy, and craniotomy, but our primary focus was the utilization of hyperosmolar therapy, specifically mannitol and hypertonic saline. So what were our results? Based on our inclusion criteria, we identified 267 severe traumatic brain injury casualties. Overall, 40 of those 267, or 15% of individuals, were captured by the registry of having received hyperosmolar therapy. So we utilized descriptive statistics and further stratified the patient population by affiliation. Based on the information shown, you can see that there are 2 broad categories that emerged, both U.S. military and other, which consists of host national, coalition, and civilian. Here we broke down the actual medical and surgical interventions. Hyperosmolar therapy was divided categorically into either mannitol, hypertonic saline, or a combination of both. Approximately 10%, or 4 of 39 individuals identified as U.S. military, had documented hyperosmolar intervention. Hyperosmolar administration percentages in non-U.S. military was slightly higher at 15.8, and 4 neurosurgical procedures were captured, all craniotomies on non-U.S. military. Of particular interest was the outcome of our service members downrange. Available associated casualty statistics included general characteristics of gender, whether the injury was battle-associated, the type of injury sustained, penetrating blunt or a combination, or burn. Overwhelmingly, the U.S. military were male with battle-related injuries, of which the penetrating mechanism was dominant. We then further characterized the mechanism of injury. Just over half of our casualties were deceased at discharge. Finally, we examined the discharge status of those who had received hyperosmolar therapy, and we noted that those receiving hypertonics had better survival to Role 2 discharge. Although I've displayed this data, I don't want to emphasize too heavily. We don't have the ISS or the AIS values, and there may have been extenuating circumstances not revealed by these numbers. So variables such as systolic blood pressure, oxygen saturation, et cetera, were not universally recorded and thus aren't available for interpretation. And it's important to note that these patients had a complex pattern of injury supported by both their mechanism and injury type, as well as breadth of diagnosis ascribed and the procedures performed. In our opinion, the nature of these injuries may have necessitated other interventions before the physician could consider or implement hyperosmolar therapy. So what conclusions? Definitive conclusions regarding the adherence to the CPGs or the clinical practice guidelines for severe traumatic brain injury are not possible. And we suggest that the pre-deployment training for these injuries can be improved, and furthermore, that it needs to be performed, validated, and tracked. We acknowledge that injury patterns of casualties are multifaceted and may necessitate other interventions before consideration is given to hyperosmolar therapy. Performance improvement goals should be the implementation and subsequent documentation of this therapy if it is implemented. And finally, neurosurgical teleconsultation as a 24/7 resource would be of value to provide guidance for surgical intervention. Thank you.